Hello, and thank you for joining CareerCert and UT Southwestern today for our webinar on pediatrics and COVID-19. I'm your host for this webinar, Danielle. At CareerCert, we are focused on providing emergency and healthcare professionals with the tools they need to improve patient outcomes. And we're so grateful for this opportunity to connect with you today and to be able to learn some potentially life-saving new information. It's my pleasure to introduce you to our presenters for today, Lyndsey van der Laan, Dr. Gil Salazar, Megan Dahmer, and Kenny Navarro. Dr. Lyndsey van der Laan works as a pediatric emergency room physician in Dallas, Texas. She worked for 3 years as a pediatric resident at Advent Health in Orlando, Florida, before moving to Texas to become a pediatric emergency medicine fellow at UT Southwestern Medical Center. Dr. van der Laan received her Master of Public Health from the University of Florida and her Doctor of Medicine from St. George's University. Her interests include pre-hospital care as well as education for both pre-hospital providers as well as physicians. Dr. Gil Salazar is an Associate Professor of Emergency Medicine at UT Southwestern. He serves as the Medical Director of EMS Education and oversees both initial and continuing education of area EMS professionals. He practices clinically at Parkland Hospital Emergency Department. Dr. Salazar is dually board certified in emergency medicine and EMS and serves as core faculty for the Emergency Medicine Residency and the EMS Fellowship programs of UT Southwestern Medical Center. Megan Dahmer completed her paramedic training at UT Southwestern in 2015 and is currently licensed through the Texas Department of Health as a paramedic. She then pursued a bachelor's in nursing at Texas A&M Commerce, graduating in 2016. Megan currently works in the ER at Parkland Hospital as an RN. Megan and her husband are the proud parents of 2 boys. Kenny Navarro serves as Chief of EMS Education Development at the Department of Emergency Medicine at UT Southwestern Medical Center. Kenny also serves as a content consultant for various project teams at the American Heart Association. Kenny is a medical and educational volunteer who specializes in teaching basic and advanced resuscitation courses in developing countries around the world. And now I will go ahead and turn the time over to our presenters today.
Hello, good afternoon, and thank you so much for having us again. We are very, very proud to continue to partner with CareerCert in bringing what we think is really valuable education to our EMS professional clinicians out there. This month, we're very, very excited to bring you a real-life case, as is our practice, that we think is going to really give you some valuable information on how to approach a very vulnerable special population, that is pediatrics, specifically when it comes to COVID-19. Move on to our goals and objectives for the course. We want to make sure that we understand the epidemiology, symptoms, and treatment for COVID-19, specifically when it comes to children. Briefly discuss MISC, Multisystem Inflammatory Syndrome in children. Discuss such adjuncts as non-invasive ventilation and some positioning strategies when it comes to pediatric patients with respiratory distress. I am very glad to be joined this month by Dr. Lyndsey van der Laan from UT Southwestern Medical Center and working clinically at Children's Medical Center in Dallas, a level 1 trauma facility. And when we partnered up, we decided that EMS would benefit from learning about her experience in the care of a very sick child. So I'm very happy to have Dr. van der Laan. Dr. van der Laan, take it away. I'll be monitoring the chat during, and please ask any questions that you want.
Good afternoon, or good morning, I guess, for some. Like I said, I'm Dr. Lyndsey van der Laan. I am a fellow over at Children's here in Dallas, and we're going to discuss a case today that I took care of about a month or 2 ago, back when the pandemic was kind of first starting. And as Dr. Salazar said, this is, feel free to ask questions, jump in and into the chat. We want to make this as interactive and as educational as possible. So we'll get started with the case presentation. So dispatch is called, and told that there is a young child experiencing difficulty breathing. You are informed that it's a 9-year-old female who has a complex medical history, and the crew that's sent out is composed of 2 paramedics and an engine crew. Next slide. Yep. When you get to the scene, you get a little bit more information. She is a 9-year-old female, has a very complex medical history, but most relevant has cerebral palsy, developmental delay, and a seizure disorder. And you find out that she's had some increased work of breathing over the last 4 to 5 days. She normally is on room air at home, but mom and grandmother who live with her have oxygen available should she need it. And over these last couple of days, they've been giving her some oxygen due to hypoxia that they noticed on the monitor. She was like 90-91%. They've also noticed some increased seizure frequency. And most relevant is that she was tested positive for COVID-19 9 days prior to EMS being called. No significant allergies, and like I said, cerebral palsy and seizure disorder are among her many problems, but those are the most relevant. Mom and grandma hand you a list. She is on 20 some odd different medications, but I listed the most relevant here. She's on a couple different breathing medications. Zopanex is very similar to albuterol. She's also on Pulmozyme and nebulized sodium chloride to help with her secretions, and Pulmicort, which is an inhaled steroid to help with her lungs as well. She's on a couple different anti-seizure medications, Keppra and valproic acid, and she's also taking hydrocortisone, which is a steroid, 3 times a day because she is does not make her own. She's a panhypopituitarism kid as well. So you walk into the room, and it becomes very obvious right away that she is in a lot of respiratory distress. This is a cerebral palsy developmental delay child, so she is in her wheelchair. And you notice that she's like hunched forward and in a tripod position. And when we see that, that's a patient who's in very significant distress. They're trying to actually increase their lung volume by sitting forward to help with their work of breathing. And mother and grandmother have put her on 4 liters of supplemental oxygen with the oxygen that they have at home. Her initial vitals, she's afebrile, her heart rate she's tachycardic to 133, she's tachypneic to 29, her blood pressure is okay at 90/52. She's statting like 93-94% on those 4 liters. And you guys were very astute and put on a capnography and noticed that her CO2 is reading at 44, which is normal, but it's in the upper limits of normal.
Dr. Vanderlaan, I'm very curious from our paramedic partners at Katie. I'd be interested to learn about what your approach is with this patient. You know, obviously we know how to take care of these patients on a regular basis, but how do you change your dynamics when you are walking into somebody who's potentially COVID positive? What's your approach with this patient?
Thanks for the question. So I think that, like you say, that on a year ago, people would have just walked into these situations and provided care to the child, and it wouldn't have been any big deal. It's just a routine kind of pediatric call. But in this new COVID era, I think there's been a huge focus, not just on COVID, but I think on infectious disease in general. And so the CDC actually issued some guidance to EMS at the beginning of the pandemic and essentially said that every patient that EMS comes into contact with should be screened for SARS-CoV-2 infections. In some cases, and the CDC's recommendation actually was that this screening could actually be done by dispatch, that in systems that had the ability, dispatch could ask these types of questions, or the 911 operators could ask these types of questions and determine a COVID risk even before EMS arrived on the scene. But in the event that that's not available, I think at a minimum what EMS professionals should do is once they arrive on the scene is to have one person fully protected, wearing their personal protective equipment, whatever the minimum level is at the time. but have that individual actually go in and make patient contact if it's possible to be 6 foot away from the patient and perform the initial COVID screen. It doesn't take very long. It's just a few seconds asking, some very important questions, things like cough, flu, fevers, COVID-19 exposures, or are there people in the house, those kinds of things. And if this individual, some people refer to them as a scout. I know some of the medics out in the field refer to them as the canary. So you send the canary in, and if the canary identifies a high risk of COVID, screens positive for COVID, then you really ought to think about, I think, if we've got 2 paramedics and an engine crew on the scene here of this call, you really ought to think about how far do you want the exposures to be. And if you have a situation, and I'm not referring just to this specific call, but if you have a situation where that canary paramedic can go in and manage the situation alone, then you don't put the rest of the team at risk. If the medic gets in there and finds something, though, that they're going to need some help with, then they can start bringing in other responders based on patient condition. So, as we see in this particular patient, this child does appear to be having some respiratory distress. And it may be a little bit more than what one medic would be able to handle by themselves effectively. And so bringing in a second medic might be the thing to do. That second medic then that comes in there should be protected to the same level as the first medic. So if the screening, for example, is positive, which our patient would screen positive because they've had a positive COVID test, then that medic should be wearing an N95 gown, gloves, eye protection, everything. And then whoever comes in to help that medic should also be wearing those same things.
It may be the case, in many departments and in many cities, regions, dispatch is asking a lot of these questions. What I've found is that the screening questions may bring some potential concern, but it's usually not till you get on scene that you really find out some more details that are concerning. And so my best advice to you is PPE until proven otherwise. Thank you, Kenny. Dr. Vanderlaan.
Okay, so you move towards your physical exam after you get the vitals. You notice she's awake, alert. She's nonverbal at baseline, sitting in her wheelchair. You go to her eyes. You notice that they're dilated, but mom and grandma reassure you that's her baseline from all the medications that she's on. But you notice that, her nostrils are flaring, which indicates that, she's working pretty hard to breathe. You move on down, and I always recommend, when you want to do a good lung exam, you want to expose the chest as well as the abdomen, especially in children, because children tend to use their abdominal muscles to help them breathe when they're in distress. So when you lift up the shirt, you notice that her belly is moving in and out. You notice when you listen with your stethoscope that there's really no breath sounds on the right at all. The left side maybe has a wheeze here and there, but more, just pronounced no breath sounds on the right. You listen to her heart, notice, it's very tachycardic. Her cap refill is a little prolonged at 3 seconds. You looked at her abdomen because you lifted the shirt, and it, looks okay. It's soft. She has a G tube, and no obvious seizure-like activity on your assessment.
Very valuable point about exposing the abdomen. I'm a big fan of exposing the abdomen for respiratory illness, especially in kids. It's not an innate thing we do. We always think it's gonna listen, maybe watch the chest, but the abdomen gives you a lot of information too. So I'm very proud of the medics documenting. They actually took a look at the abdomen and even were astute enough to notice there was a G tube. So Megan, I want to hear your thoughts at this point. You have a pretty good history, pretty good exam, and since we do have kind of COVID positive considerations here, what's your approach with this patient and your differential diagnosis?
So I would definitely, as we talked about, ensure PPE, not just for myself, but for the patient, and then also for the mom and grandma, because they've obviously been exposed. And I would utilize them as best as I can as resources. It sounds like that they our primary caretakers and know more about this girl than I can ever learn, and however long I'm going to be on scene or in transport to the hospital. I'd asked them what meds she's been getting, which, you know, we had the med list. Based on her breath sounds decreased on the right, you know, that kind of perks my ears up. Maybe does she have a pneumo, like worst case scenario? If she has COVID, which she has COVID for 9 days now, and I know that, you know, it can progress to pneumonia, and want to make sure she doesn't have the flu. Just because it's not flu season doesn't mean you can't get it. Make sure she's not having any sort of like asthma or anything that's getting worse. Treatment-wise, she's already on steroids. I might call and see if maybe we can give her a little bit more. I would try to get an IV, see if maybe we can get her something through there. I'd consider nebs, maybe CPAP. How long has she been on this nasal cannula? That's something that I would want to know. Has it just been that day? Has she been on it for 3 days and they've slowly increased it? And then maybe Tylenol for fever. She is medically complex, so the best thing and the quickest thing I would want to do is get her to the hospital.
You know, and then there's that concern you mentioned, CPAP, nebulizing medications, and the concern for nebulized particles. I'm interested. That's a pretty aggressive approach, and I don't disagree whatsoever. I'm curious to see Kenny, whom I've known for a very, very long time, a very conscientious medic. Kenny, do you share that concern as well, or are you more conservative with this patient?
So I think that that it is, again, a year ago, there wouldn't have been any question. Megan's approach is absolutely the appropriate thing to do, but with this renewed, you know, I think rightfully so, interest in infectious disease transmission, you know, I don't think that there's any medic out there that doesn't understand the concept of you can't take unnecessary risks. And if you have a situation where the risk to your team outweighs any potential benefit to the patient, then it's not anything that you would do. And so as an example, if you have you know, individuals that where your patient is under fire, your patient is in a location that you can't get to them because of gunfire. Well, I don't think that anyone, there's any medic who would say, oh, just run across the yard, even though you're unprotected, because you got to get to the patient, you got to help them. Everybody has to take their own personal safety first. So in this particular case, I think it's, you know, it is the things that Megan talked about are aerosol generating procedures, and aerosol generating procedures do increase the risk of disease transmission, you know, of COVID transmission. And so we have to weigh the benefits versus the risks. And I think the risk to whoever's going to be there at the patient's side goes up significantly with aerosol generating procedures. You have to weigh that against what is the benefit to the patient. And if you have patients that can be managed effectively with alternatives that don't generate an aerosol, then perhaps that's a better choice, even though it might not follow a written protocol exactly. I think that there has to be some room for, you know, for lack of a better term, protocol deviation in order to keep your team safe.
You know, most agencies have recommendations by clinical guidelines and protocols regarding nebulized medications. I'm going to be very curious to see the results of this poll here shortly and see what people think. As I imagine, yeah, there's a little bit of quite a big split in terms of nebulized medications versus not. I mean, it's almost 50-50, so not surprised at all. 47% of you want to give nebulized meds, 22% defer them, and then use the patient's metered dose inhaler, 31%. So yeah, 50-50 as I expected, and I think there is no wrong answer in this, but the considerations you mentioned are pretty valuable. Let's, Dr. Vanderlaan, let's see what was done in routes.
So the did a POC glucose, which was within normal limits, and the crew decided actually to defer the breathing treatment. as well as defer placing the patient on a non-rebreather and decided to transport with just the nasal cannula. They did attempt the IV, but as I'm sure we all know, kids, especially medically complex kids, sometimes those are very difficult to get. And they got some reassessment vitals, heart rate still tachycardic, we're still tachypnic at 28, but we're starting 94% on, 4 liters. Our CO2 is about the same. And, looking at this and per our discussion we've had so far, I think it's completely understandable to defer these nebulized interventions. Like we're talking about, it is aerosolized producing. And when you kind of have to balance what's best for the patient and what's best for you. And if mom and grandma said this patient is, yes, she's in distress, but, she's awake and alert and, kind of at her baseline, I think it'd be okay to defer a more aggressive approach. But as we will see as we move forward, she does not get better, and maybe a more aggressive approach up front could have helped, but we don't know.
Sounds like a pretty sick child. And this, what you see next is what you saw at the, once the patient is under your care?
Yes. So I get involved, obviously, when they get to the emergency room. Any kid who is potentially this sick goes back to our critical care room. And we're given very limited information up front. We're basically told the same thing: complex kid, 9-year-old, respiratory distress. And at our institution, any patient who comes in with anything that could be COVID, like cough, congestion, fever, we treat them as something called a PUI, or a person under investigation. And the reason that's important is that we have to gown up and put on our N95s, our goggles, our glasses, face shields if we wear them, and gowns and gloves before we go into the room. But once we walk in the room, we get some vitals. Her blood pressure now is getting a little soft. It's 82/47. Her heart rate's still high at 122. She's still very tachypnic. And her O2 stats are now starting to drop. She's now 88% on 4 liters. She is in significant distress. She is awake. She is alert, looking around the room, kind of at her baseline, but she's in significant respiratory distress. She's very tachycardic. She has a delayed cap refill, which lets me know that she's not perfusing very well. And when you listen to her lungs, and kind of like we mentioned before, you could not hear much on the right side, to the point where, I thought my stethoscope wasn't working, but you can hear breath sounds on the left, but the right sound is just very, very diminished. And then when you go to a neuroexam, it's very hard to assess a neuroexam on a complex child who is nonverbal. But she's not having any active seizure. She's withdrawing to pain, which is kind of her baseline. And when we're in the ED, we get a little bit more history, similar to what EMS got, that she is COVID positive. And I think that becomes very important. And it kind of changes your thought process, and it kind of widens your differentials. At first, walking in the room, a complex child, my initial thought is, okay, does she have some sort of underlying chronic lung disease that maybe is flaring up? Does she have aspiration pneumonia? These kids that aren't mobile, have G-tubes, they're very high risk for that. Does she just have asthma? Something along those lines. But once I hear COVID, now my differentials are going to expand. And that's because of these complications that we've seen specifically in kids. So now I'm on top of the first differentials. Now I'm thinking very large pneumonias. Could there be a pneumonic effusion? Could she be in heart failure due to myocarditis? Or could she have something called multisystem inflammatory syndrome in children, or MISC?
And the pneumonic effusions that you mentioned is basically fluid around the lung. And I assume that you might show us an X-ray or two.
Yeah, and so because you don't hear any lung sounds on the right, and it's only unilateral, I became very suspicious that there was an effusion or fluid around the lungs that was kind of blocking what I'm hearing. And I know we talked about earlier, it could be a pneumothorax as well, which is air trapping, which is also possible. But when you think about the clinical story of COVID and fever and infection, my mind kind of goes to pleural fusion first, with air, a little bit lower down. So we're looking at this X-ray, and just to kind of orient you, remember the left side of the screen is the patient's right, the right side of the screen is the patient's left. And just to kind of orient you, there's some white lines that are kind of crisscrossing the chest. That's the EKG lines. Those are just kind of in the way. But you can see in the middle, the trachea. The trachea opens up to 2 lungs, which should be full of air. So it should be kind of black to dark gray. But you can see that they're kind of patchy. which what we would call opacities or multifocal opacities, which is consistent with pneumonia. But on that right lung, to the left side of the screen, you can see that there's this white that's kind of pressing on the lung and kind of shifting it inwards. That is all fluid, so highly likely to be a pleural effusion, which is what's causing this decrease in breath sounds and inability to hear anything on the right side of her chest. So what did we do in the ER, just quickly? So when she gets called back into the critical care room and we notice that, she's 88% on 4 liters, and we get very suspicious that there's a pleural effusion on the right. We know that we need to escalate her respiratory support. So we transition her over to CPAP, which is positive pressure. And she does improve. She goes up to 91% oxygen. And we get an initial venous blood gas, or VBG. And those tell us how well the patient is oxygenating and ventilating down at the cellular level. So her pH is, she's a little acidotic at 7.3, and her lactate's a little bit high at 1.75. At our institution, anytime we transition someone to higher respiratory support, we want to make sure that they're actually getting better, not just the numbers on the screen. So we actually repeat that blood gas after she's been on CPAP for 15, 20 minutes. And you can see her pH drops to 7.21. And I think at this time her CO2 was like 100 and something. So we know that she's not ventilating. She's not doing well on the CPAP. And so one of the things we actually do is we know that there is, from that x-ray, there's fluid around that right lung that's kind of preventing her oxygenation and ventilation. So we actually relayed her on her right side. And what that does is it allows you to open up the left lung, or her good lung, to allow for some more oxygenation. And it buys us a little bit of time in order to get set up for intubation. After 2 attempts, she is intubated and does eventually get a chest tube on the right side to drain that fluid out. So, I think, which I think you're about to talk about, Dr. Salazar, is, setting up for intubation and what is the best way to get her pre-oxygenated.
Certainly, clinically, this child is ventilating poorly, oxygenating poorly, and in modern medicine, I think the term rapid sequence intubation should be kind of almost extinct now, in the sense that we have to delay intubation and even induction until we have proper pre-oxygenation. So I can only imagine how difficult it is in this patient particularly to kind of see where's the fine line between pre-oxygenating enough versus we have a deterioration in ventilation. So I'm very curious to see how folks would choose to pre-oxygenate this child. Folks want to keep them CPAP, definitely a great option. Transition over to BVM and control that, definitely a good option. And then nasal cannula and non-rebreather, also a good option. So of all these options, Lyndsey, you guys stuck to the CPAP. What are your thoughts on the BVM versus transitioning them over to the non-rebreather nasal cannula?
I mean, I think knowing that she has a pleural effusion, which is pressing on her lung, I think it's important to remember that pressure is her friend. So whether you do that via CPAP or if you can get a good seal on your bag valve mask and still give her a little bit of pressure, I think either one of those would be wonderful. Now, I think nasal cannula and a non-rebreather would probably also help, but I think out of all of them, I think a pressure option. We know that while we kept her on CPAP, while we let her later on her right side to kind of buy us some time. And it did actually take 2 attempts to intubate her, because once we pulled her off CPAP, her oxygen just, tanked. She went down to, I think, 12% oxygen saturations quite quickly. So we realized that she needed the pressure.
That's definitely a very classic COVID type of presentation, when that O2 sat absolutely tanks. You mentioned pressure as our friend, and definitely the ability to provide CPAP in the back of an ambulance can be life-saving. So I think both BVM and CPAP are good options. I think keep taking the CPAP off to bag somebody, if you can do that really expeditiously, that should be fine. Megan, what do you think? What would you have done? Keep them on CPAP, BVM?
Being the aggressive paramedic that I am in course of action, I would have contemplated keeping him on CPAP, but my concern with BVM is, you know, as tachypnic as she is, it sounds like she's uncomfortable and probably in pain, and I don't know how much she'd be fighting me, you know, and if she's already tachypnic and I'm having to breathe with her with the BVM, like, am I getting enough support in there? But just really letting the CPAP do its job and helping her. But I guess I would just have to see which one she's responding better to. If she can tolerate the CPAP, then great. But if not, then maybe talk to mom and see what we can get to give her to relax maybe a little bit and help her breathe better with the BVM.
That's a great thought. You know, if she's tolerating the CPAP, and even if we're not going in the right direction, we got to take into consideration what does, you know, ketamine or an induction agent, will that affect her capability to self-ventilate and oxygenate? I want to address an item on the chat. Somebody mentioned MAC sulfate as a potential adjunct to the carrier providing. Definitely a great medication for smooth muscle relaxation, and particularly in bronchoconstriction. I think if that's really high in your differential with this patient, I think it would be a good option. I think that since you have a big pleural effusion because of absent breath sounds, etc., I think that's probably your source, and I don't think that it was so much bronchoconstriction. However, if bronchoconstriction remain very high in your differential, they're not responding well to bronchodilators, and especially if you start having to think about epinephrine for bad bronchoconstriction, then yeah, in your arsenal, you should definitely be throwing in some MAG. All right, Dr. Van der Laan, tell us a little bit more.
This is Kenny. Can I just add one more thing?
Sure, of course.
So if we were trying to make the decision in the ambulance, if we were still in the field and trying to make the decision about induction and intubation and getting control of that airway, then I think, you know, one of the things that, again, I've sort of been harping on this through this presentation, and that's the safety factor. And so, you know, I was a little bit hesitant about some of the bronchodilators in the beginning because of the potential for aerosol generating, you know, droplets. And certainly CPAP can do the same thing. You generate aerosol. Now, if the decision is made because this child is getting worse and you have them now on CPAP and you're in the back of the ambulance, if you have CPAP, if we're still on the scene and we're trying to make these decisions, then I think in the back of the ambulance, we probably need to, once again, limit the number of people that are back there so that you don't run the risk of transmitting this to your entire agency. So have the back of your door, the doors of the ambulance open, have the air conditioner on full blast, blowing some air through there, have the CPAP going. And then once you make the decision to intubate, if that's done, then ideally you would have a viral filter that you could place on the endotracheal tube. So now you have control of this airway. You're not generating these side droplets, this side air from mask seals, etc. Everything's coming in and out of this tube. And if you can run it through a viral filter, then that provides you, I think, the best airway control safety measures that you can probably get in the field. Now, on the other hand, if you're trying to transport this child with CPAP, hoping that you can make it to the emergency department before the patient needs to be intubated, then again, whoever's in the back of that ambulance is going to be at an increased risk. So try to limit the number of people back there. And this is a balancing act because you're going to want enough people back there in case something catastrophic happens, like cardiac arrest. But on the other hand, the more people you have back there, the greater the risk of disease transmission.
You know, you may even be into a bad situation, like somebody in the chat mentioned. What if it's just me and I'm a basic and all I have is BLS available to me? Then what do I do with somebody like this. In that case, then that's why I harp on BVM ventilation being one of the main skills, that and the application of a tourniquet on a timely basis are the two main skills that an EMS professional should have. So if all I have with me at that period in time is a BVM, then I'm going to pre-oxygenate and ventilate that child with my BVM till kingdom come, and get them to a definitive care as quick as possible. So great question in the chat. So Dr. Vanderlaan, what caused all of this?
Well, I think that's a great question. I think her main underlying problem was the COVID-19. This is something we see in children who get diagnosed, a week or two later, when they come in with these, what started off as, your typical cold-like symptoms. They develop a bacterial pneumonia on the right, just because their body is, fighting something. And then they develop these large effusions. And her problem was she had COVID-19 and not great air clearance. So I'm going to briefly talk about COVID-19 in children. I am a pediatrician as well, as a pediatric EM fellow. So I get a lot of questions about COVID-19 from friends and family. And the two questions I always seem to get is, are children affected and do they get sick? So I looked up, as of September 10th of this year, there are over 500,000 children who have been reported as diagnosed with COVID-19. And I think what's interesting in this data is that it's actually been increasing every week. So we didn't see a lot of cases in the beginning of the pandemic, and that might have a lot to do with testing and access. But we're starting to see, as the weeks go by, that each week we're seeing an exponential increase in pediatric cases. Of all cases that have been found in the United States, children only make up about 10%, and the deaths are only 0.3%. So the next question I always get is, do they get sick? Which has been, there we go. And we don't have much data on it. I mean, as we all know, this pandemic has only been around this year. But what data we do have was a study that was kind of done at the beginning of the pandemic, from March to July, and showed that the hospitalization rate amongst children were 8 per 100,000. And to compare that to our adult colleagues, adult hospitalization rate is 164 per 100,000. So you're telling me, okay, well, that's not so bad. Kids aren't really getting hospitalized. But when they looked at the children who got hospitalized, they found out that 1/3 were actually getting admitted to the ICU. So when you think about that, 1 in 3 hospitalized children end up in the ICU, which is exactly the same as the adult population. And to put that in comparison to things like the flu ICU rate is much lower. It's like 15 to 20%, not really 33%. So who's at risk in our pediatric population? And it's really the younger children, less than 2. So you can see in that chart on the left, the blue dotted line, that's children less than 2. And like I said, you can see this kind of exponential increase as time has gone on. And it's mainly in our younger children. And then which types, or like which patients, which of our less than 2-year-old, we found there has been a higher risk and rate of infection in our Hispanic and Black populations. And 42% of the children had underlying medical conditions, similar to adults. But what I thought was interesting is that obesity was the #1 related. And I know most people don't really think of obesity as a medical problem. So how do children present? This is a very busy slide, but the thing I want you to get from it is that the younger children tend to present with more fever, congestion, cough, kind of like those URI-like symptoms, whereas our older children present similar to adults, more cough, more headache, and that loss of taste or smell that we see in the adult population, we're seeing in our older children as well. And I think one of the most important things I get is, what can I give my child? And there's been some studies, but it's kind of all over the place when it comes to what's the best treatment. We all know for most viruses, everything is supportive, and what is good and what helps. So we know albuterol can help, especially in our children who have asthma and have underlying like reactive airway disease. The recommendation from the AAP is that you try to use their MDI, their inhaler themselves, and try to avoid nebulized machines because it does produce the virus particles into the air when you can. And then the question is steroids. So for routine pediatric patients, so your patient who comes in who's maybe, or you see who has maybe a little bit of a fever, cough, congestion, they really don't recommend steroids. There's been some increase in morbidity and mortality with steroids for routine use. However, if it is a patient who has underlying asthma, or you think this is a croup-like cough, that barky-like cough, steroids are actually okay and safe to use in those situations.
Dr. Vanderlaan,
we're going to briefly.
Many EMS agencies have things like dexamethasone, prednisolone on their arsenal of medications. So it sounds like if there is significant concern for bronchoconstriction, particularly if we're limiting the amount of nebulized medications, perhaps steroids and things like magnesium and stuff could be good possibilities for these patients?
Absolutely, if you're thinking that the underlying medical problem is related to the bronchoconstriction. So those reactive airways, asthmatics, our croup patients where things are just really tight, and you're helping that, the albuterol and all that type of stuff, and magnesium is going to help, then steroids are absolutely safe and fine to use.
Thank you.
When we look at other treatments, and I'm just going to briefly mention these because these are in the news and popular. Dexamethasone, the adult literature shows it's great for our very, very sick patients, similar in children and adults, but the trials are still kind of ongoing. Remdesivir is something we use at children's in our PICU. Again, only in our severely ill children, as well as our hydroxychloroquine. Hydroxychloroquine we're not using because the clinical trials are kind of all over the place for adult literature, and there's really no children literature on it yet. So right now we're just using remdesivir at our hospital. And I want to talk about this kind of unique phenomenon called multisystem inflammatory syndrome in children, or MISC. Just kind of briefly, and what is it? What is this syndrome? It's a rare complication that we see, and it's only in children. But the AAP came out and said that any child who has died from COVID has likely died actually from MISC. We just may have not known about it yet. And it results kind of from this abnormal immune response to the virus. So most patients are actually not going to be PCR positive for COVID at the time of presentation with MISC. Some still may be, because we know that people can test positive for weeks, but they may not test positive, but they may have antibodies. So some sort of recent infection of COVID. And you present with any sort of evidence of inflammation as well as 2-organ involvement. And so they present more, again, with the fevers that we see in regular COVID, but you're going to see more things like rash, and it'll be a diffuse red rash kind of all over the body. They'll have conjunctivitis or bright red eyeballs. They may have cracked lips and a strawberry tongue, and they may have some swollen extremities. And the reason this is all kind of important and why we need to know about this illness is just because of how sick they can get. So MISC actually has a large myocardial involvement. It can cause them to have heart failure. It can cause them to have dilation of the coronary arteries. It can cause huge effusions of the heart, leads to shock and kidney injury and death. And it has a very high mortality rate. So recognizing this kind of early on is helpful because there is a treatment we can attempt to actually help the heart.
Dr. Vanderlaan,
so I just want to, yes.
I was just wondering, going into with what you've covered on what these COVID kids and the MISC, how they can present, since, we're on the cusp of going into the flu season, with the kids that we know that the flu can run rampant with, how can we differentiate between flu versus COVID? And then do we even need to worry about that? Is there a different approach we should take for either side? Or would we treat them just, umbrella the same and just take care of them the way that you have already described?
That is a great question, and one we talk about in the ER all the time as we are going into flu and RSV and parainfluenza season. And I think it's very hard to tell the difference, and I don't think clinically you can. Flu presents with cough, fever, congestion. They can have, especially if they have underlying lung problems like asthma, they can have really significant respiratory distress. So I think knowing which one it is when you get to the scene or when you first see that patient is not nearly as important in that moment, except for the fact that you should probably wear your N95s and keep yourself protected because you don't know if it's RSV, flu, or if it's COVID-19. So keeping good PPE to keep yourself protected and knowing that, it kind of let the patient guide you. If you hear wheezing and evidence of bronchoconstriction, then go down your bronchoconstriction pathway with, maybe epi and albuterol and magnesium sulfate. But if you don't hear those things and you're not thinking bronchoconstriction, there's, just supportive care with what you would normally do. Increase your respiratory support and do what you can do to help the patient.
Plus I think that our use of PPE and how we deploy it is going to be universally different going forward. I see a lot of discussion now, a lot of talk about universal masking. And you know what? I'm probably going to institute that even in my own practice, because it is going to be very difficult to tease these things out. Things like Kawasaki's or MISC, all these items can be caused by various viruses. So very difficult to tell. And until I know that I have proper humoral immunity against COVID-19 and other life-threatening things, I'm going to continue to do universal PPE. So I would encourage our friends who are watching to start helping your departments make these decisions. And yeah, it sucks wearing a mask for that long. I get it. But if it keeps me and my family safe and keeps me working, I'm going to keep doing it.
Agreed. So just want to go back to the case. So remember, it was a 9-year-old complex care child who was in severe respiratory distress, hypoxic, hypercarbic, who had, decreased breath sounds on the right. We find out it's definitively a pleural effusion later, but even on the initial assessment, there's, you can kind of get some clues that there's unilateral decreased breath sound. So there's probably some fluid in there that's causing some problems. So what could we have done, kind of early on when we first saw the patient? And if you were to ask me that, my 2 answers would have been non-invasive ventilation and positioning. And we'll quickly talk about them. And I know you guys know what non-invasive ventilation is, but just remember that's any sort of respiratory support that doesn't require an endotracheal tube. And we use this to help decrease the patient's work of breathing and to help kind of recruit our alveoli to help us. So there's 2 different types of non-invasive ventilation. It's basically CPAP and BiPAP, and it just determines what type of pressure support you want to give your patient. And when should you use CPAP or BiPAP? Indications are on the next slide. And these are things that all of you would be able to figure out. If the patient is not getting better doing what you're doing on nasal cannula or a non-rebreather, it's time to step up that support. If they're persistently tachypnic, or if they're requiring very high levels of FiO2 on your non-rebreather, this is time where you need to start thinking about giving a little bit of pressure and a little bit more of support. Obviously, the respiratory acidosis you're not going to know out in the field, but those first 3 items you could easily assess to determine if a patient needed some additional support. The last thing I would think,
Dr. Vendelon, I'll be very curious in hearing from some of our attendees today. There are some flight services, for example, that carry pretty fancy, very advanced non-invasive ventilation devices. And then we have most ground ambulances have transport ventilators. I'll be very curious. Put it in the chat if you have any thoughts or want to share what your ventilation capabilities are. Do you have access to things like BiPAP in addition to CPAP? So I'm very curious.
Absolutely. I mean, and the last thing I would mention while people are typing away is kind of positioning of your patient. Always try head of the bed upright. Most times patients will naturally try to sit up and sit forward. But, the one thing I would, kind of leave this thought in your head is if you're very concerned that there could be a pleural effusion, the story makes sense, they've, been sick, they sound infectious, and you have that decreased breath sound, especially on one side. When it's bilateral, it's very hard to, determine if that's heart failure or asthma or a lot of other things. But when it's one-sided, you really are starting to think, is there some fluid there? And you really can help your patient out by trying positioning. And I always tell people you want to put the good lung up. So if the one lung is being compressed by air, by fluid, sorry, there's really nothing you can do in the field for the fluid. The patient's going to need a chest tube to get the fluid out, but you can help that other lung. And remember, air rises. So if you put the good lung up, that could probably buy you some extra time, and the patient might actually become much more comfortable by trying that.
One question that has come up is a very smart medic may ask, well, we got decreased breath sounds on the right. How do I know it's a pleural fusion? So let me put in a quick plug for something I think we should integrate more into EMS, and that is point of care ultrasounds with a very quick, very fast, with a very well-trained medic. You can differentiate between absent breath sounds because there's fluid within the thorax, or it's more air than usual because of a air within the thoracic cavity that doesn't belong there. So Megan and Kenny are well aware that I'm a big fan of point of care ultrasound for making these differentiations in real time. And in this child, Megan, what do you think? Or Kenny, do you think a point of care ultrasound could have made a difference?
Go ahead, Megan.
Go ahead. No, you go ahead, Kenny.
I was just going to say that I'm not sure that even it might have helped in a diagnosis, but I'm not really sure that it would have changed anything that the medics had to really consider in their care. Most of my comments have been about protecting the medics, everybody trying to stay safe. Knowing for sure that this was a pleural effusion wouldn't have changed that. You still would have had those same concerns about, do I want to risk CPAP? Do I want to risk, any type of a nebulized treatment, endotracheal intubation? What are those risks? So I don't disagree with you that it's a useful tool. I'm not really sure, though, in this case that it would have changed anything. But I could be wrong.
I think that if you get a quick point of care ultrasound and you see air in there, you're probably going to be more hesitant to start him on non-invasive ventilation, and that's probably going to be what differentiates kind of the treatment between using CPAP and just plain old oxygen. Thank you. I see that a lot of you are using CPAP BiPAP. Some of you are using straight up transport ventilators. Some others are looking to kind of go up the ladder with it. And with that is going to come the time for things like point of care, blood gases, and teaching our medics how to interpret those. I'm going to leave it open for any questions. I'm really happy that Dr. Vanderlaan joined us, and I'm hoping she'll join us for other opportunities. If there are specific topics related to pediatric emergency medicine that you want to see, well, she is just down the road from us, and I'm sure I'm going to volunteer her for future opportunities.
Absolutely. I love talking about kids.
One last question that I have for you is it safe to give patients steroids in the pre-hospital setting if they're already on home steroids, like this child has nebulized steroids at home?
Absolutely. In fact, patients who are on chronic steroids, parents are very good and they're very educated on knowing that when you're on chronic steroids and you become acutely sick, they actually need more steroids. So a lot of times parents will already start increasing the dose at home, but it is actually safe to go ahead and give them steroids prior to arrival to the ED.
Very cool. Thank you so much, Dr. Vanderlaan. Thank you, Megan. Thank you, Kenny. Thank you, Paul, on the line. Thank you, Danielle, on behalf of all of us at UT Southwestern. Thank you to CareerCert for the opportunity. Thanks to all of you for attending, and please let us know how we did. what things you guys want to see in the future, we're more than happy to bring you all of this education.
Perfect. Thank you so much. This was such wonderful information. And Paul, I noticed a few people have asked if we can switch back to the references really quick so that they can jot those down. So if you could move back just one slide, that would be wonderful. Thank you guys so much for joining us today. We're so grateful to have been able to be here with you. We'll make sure and get you access to a lot of these references so that you can see them. It's been wonderful to connect with all of you and to start this important conversation, and we'd love to continue the conversation with you. Please visit us at careercert.com to view this webinar later on or to access other free resources to keep you, your patients, and your fellow providers safe. Thank you again, everyone, for connecting with us today, and thank you so much for your sacrifices to make our communities safer places. Take care and stay safe.